Everyone, and welcome to today's Alliance discussion. And I hoped you joined us yesterday. This is a twofer this week, but I'm really looking forward to today's conversation. If you are not, your organization isn't a member of Research America, and I'm sure you've heard me say this before, please think about joining our alliance. We're really stronger in our advocacy for R&D with the help of our alliance members, the kind of the reach of our alliance members across the country. And so if you wouldn't mind, if you're not a member, reach out to Joel from our team, who is our director of membership, and his email is in the chat. And to those of you who are from Research Alliance member organizations, thank you so much for your partnership. We really, really do value it. One more bit of housekeeping. If you wouldn't mind typing your questions into the Q&A box or also the chat, and we'll pose as many as we can during that portion of today's session. As many of you know, I'm guessing because you're here with me, we have a terrific guest speaker today. Dan Farmer, colleague and friend from, he's a principal at the Health and Life Sciences practice at BGR Government Affairs. And I think, Jacqueline, if you drop his bio in the chat, that'd be great. We've asked Dan to fill us in on a new coverage pathway that CMS is actually right now asking for comments on. And it is for breakthrough medical devices. That means they've gotten a designation as breakthrough by FDA. And, you know, this has really important implications for patients, not just of medical devices, but really all patients. You know, and I think, and also kind of the way medical progress looks going forward. So this is a big deal. And that's why I'm so thrilled we have Dan. And let me turn it over to you.
Hey, everyone. First of all, Ellie and everybody at Research America, thanks very much for the opportunity to be here. I'm really excited to have a chance to talk about what's going on with CMS and coverage of breakthrough devices. I'm going to put up my slides in just a minute, but before I get started, just wanted to share roughly what the format is here. We're going to try to go back in time a couple of years because there has been a lot of relevant policy making over the last couple of years. Try to walk through how CMS has looked at this issue differently over the this and previous administration, and ultimately get a sense of where we're going next. So, without further ado, all right, I believe you all should be able to see this presentation. Please let me know if for some reason you cannot. So the ultimate question we're trying to answer here is actually remarkably ambiguous. How does CMS decide what projects are quote unquote reasonable and necessary? Where that comes from is a statutory requirement for what dictates what Medicare covers under Parts A and B. So first of all, there is a requirement that things that are covered in Medicare have to be fit into what's called a benefit category, which for most of the things we talk about typically isn't a major issue. There are a lot of different benefit categories that CMS has. They just have to make sure that it slots under one of them. Make sure there's no statutory exclusions. But the big question is the statutory requirement for Medicare Parts A and B to cover an item or service is that it must be reasonable and necessary for the diagnosis or treatment of illness or injury. And that's a very broad term. And interestingly, CMS has a lot of authority in how it interprets what could be reasonable and necessary. And in candor, there may be times different administrations look at the question differently. So let's say I've developed a product, the FDA has said it's okay, but we're looking for CMS to make a determination or trying to figure out how CMS and Medicare are going to decide if that product should be covered under Parts A and B. And there are a couple of different pathways. The first is a national coverage determination, where CMS is asked to do an analysis of a product or a category of products and make a decision whether or not that meets the standard for reasonable and necessary. Now, the second pathway would be through a local coverage determination, an LCD, where CMS actually outsources the decision to their payment contractors. So CMS, this is sometimes a common misconception, CMS does not have a building with 6 floors of claims processors in it. CMS actually contracts out all the claims and billing work to individual contractors. Now, with that contracting out, they also give those contractors some authority to interpret statute and regulation based on their own best judgment. So CMS actually allows these individual contractors to come up with their own local coverage determinations for coverage. And then lastly, just to make this totally wild, they can do a claim by claim adjudication, which means they just look at a claim and say, yeah, this looks right, and approve it. And just to give you a sense of the number of MACs around the country, you'll see they all cover a geographic area. So if a MAC makes a local coverage determination that's relevant to that specific geographic area they cover. Now, it is possible, and CMS has talked publicly before about that different MACs can take different approaches to specific coverage questions. That's sometimes where the NCD is valuable as opposed to a local or claim-by-claim decision. So one thing to think about, though, is an NCD or an LCD is a timely process. CMS or the MAC has to release a proposal, ask for public input, and then release a final. And that can take 9 to 12 months. So if the FDA has approved my product, I'm now coming to CMS saying, hey, I want you to decide if it's going to be covered. It can take 9 to 12 months for CMS to make a determination. So this led to what is frequently called the MCIT rule. So in January of 2021, CMS, under the Trump administration, finalized a regulation that created a Medicare Coverage for Innovative Technologies pathway, the MCIT pathway. And again, this was specific to medical devices that were designated as breakthrough by the FDA. And it gave 4 years of automatic Medicare coverage for any breakthrough device effective the date of the FDA approval for marketing. So if the FDA has said this is a breakthrough device and it is approved and good to go, CMS would immediately begin a period of 4 years of Medicare coverage for that device, no questions asked. And that was scheduled to take effect in March 15 of 2021. And just to get a sense of what CMS estimated the impact would be, you'll see they weren't anticipating there'd be a huge number of manufacturers that jumped on the opportunity. In the first year, 2 manufacturers, in the second year, 3 manufacturers, and then sort of gradually building over time. And I pulled this up, I think, because I wanted to show the sort of directness of the language that the Trump administration CMS was using as they brought the MCIT pathway forward. So first, in the press release, they referred to a quote-unquote valley of death, and they brought that term up in a number of other places that refers to that lag time between when the FDA approves a product and when CMS and Medicare decides that they're willing to cover it. And then here's the specific quote that was attributed to the CMS administrator at the time, Seema Verma. Said, arcane bureaucratic requirements have no business preventing seniors access to a technology that might save their lives. So that's pretty direct language that they were using at the time.
Hey, Dan, can I ask a quick question?
Yeah.
You may get to this, but could you give us just a quick definition of a breakthrough medical device as FDA defines it?
Yeah, sure. So the FDA has a designated pathway for devices. I don't have the legal definition in front of me that it designates as being particularly valuable or ability to treat an area that doesn't have a lot of existing, products, in the sense that it's offering something new and innovative to the market. So I apologize, I don't have that definition pulled up.
Oh, no, it's fine, but it's either filling an unmet need or it actually is a really important innovation for patients. Okay, that's really, really helpful. Thanks so much.
Correct. Yeah, and and toward the end of the talk here, I'll pull up that definition so everybody has a chance to share it. And apologies, I don't have it in a slide here.
No worries.
One other aspect of the rule I just wanted to note that doesn't get a lot of attention is, in addition to creating the MSIT pathway, the regulation that CMS put forward tried to put a little more meat on the bone of that question of how CMS defines reasonable and necessary. Now, most of what they did in that regulation was just moving some of their sub-regulatory guidance, like one of their manuals, into formal regulation so everybody could see it. But there was a new provision that CMS included that would allow CMS to consider whether or not insurers in the commercial market were covering a policy if CMS was not. And here's the specific regulatory language here. Some of the beginning might not make a sense, but it says CMS will consider coverage to the extent the items or services are covered by a majority of commercial insurers. What this language would have done is said that CMS can now say, hey, if we're not sure if we should cover this, or even if we have an opinion one way or the other, we can also go out and look at how the commercial market, and this is not Medicare Advantage plans or Medicaid managed care plans, these are just commercial insurers of the small group and large market and the employer market, and see how they're approaching this topic. And they could factor what those other insurers had decided to do in CMS's decision whether or not to cover an item or service. And this actually would have applied beyond the breakthrough devices. This would have applied to the broad definition of reasonable and necessary. But you'll notice I used the term would a couple times there. Sure enough, the MSIT rule and that other piece of the regulation did not actually come to pass. A funny thing happened between mid-January 2021 and March of 2021, which was when the regulation would have taken effect, which was we had Inauguration Day and a new administration came in. And as part of coming in, an administration typically issues a regulatory freeze, as this administration did and the administration before that did, that pauses implementation of any regulation that hadn't yet taken effect. So sure enough, the MSIT rule had not yet taken effect and therefore was subject to the freeze. And in March 2021, CMS announced a delay in the effective date by 60 days. Now, it was interesting about CMS's decision to delay this rule for 60 days is that CMS also took that opportunity to lay out some initial concerns that CMS now had with the regulation it had just finished 2 months prior. And at the time, CMS was delaying implementation of multiple regulations, and certainly there were other parts of the government that were freezing implementation of regulations. But in a lot of cases, they were just announcing a delay of 60 days without a lot of explanation. In this case, CMS took the additional step to say, we're delaying by 60 days. Oh, and by the way, here's some things that we think are problematic about the rule we just finalized. So the concerns that were outlined at the time first were operational issues. CMS identified concerns with how they were going to be able to set up coding and payment methodologies for these new products that were granted immediate Medicare coverage, i.e. the Medicare coverage would start before CMS knows how to pay for, how Medicare would know how to pay for those products. Second, on potential for overlapping rules, CMS had already started a separate regulation in effect that was going to change the benefit category determination process. There was a potential for conflict, although CMS has since rescinded that change in the BCD process. CMS also suggested that the data that had been presented about the number of breakthrough devices that are out there in the final rule had been, I think, not artificially low, but based on older data. So specifically, they noted that the MSIT rule had said at the end of 2018, there were 97 FDA breakthrough devices out there, but by the end of 2021, they were seeing over 400. And they thought that might suggest that there would be more manufacturers out there likely to take up the MSIT pathway. And then lastly, just a little thing, Medicare patient and benefit protection issues. And here's where they specifically called out concern around whether or not there was a sufficient, the MCIT rule was leaving them with sufficient evidence base to determine Medicare coverage of these new technologies. Now, this ultimately led to, at the November 2021, later in the year, CMS announced that they were going to formally repeal that MCIT rule in its entirety. Now, the key theme I want to bring up here is, you'll notice the quote, safe and effective versus reasonable and necessary. So a lot of you are probably familiar with the term safe and effective. That's sort of an oversimplification, but it's FDA's sort of general standard for approval of a product. Is it safe and effective? CMS technically has a different regulatory and statutory standard for what should receive Medicare coverage than the directive for the FDA. And CMS pointed out that issue a number of times. And specifically, CMS said they were concerned that if this MCIT and reasonable and necessary rule were finalized and were implemented, it would not be in the best interest of Medicare beneficiaries because, and this is the quote I have up on the screen here, the rule may provide coverage without adequate evidence that the breakthrough device would be a reasonable and necessary treatment for the Medicare patients that have the particular disease or condition. So CMS continued to point out that the FDA may have had sufficient evidence to make its determination of whether or not the product was safe and effective, but CMS was concerned that that evidence base that the FDA was using wouldn't necessarily have the information available for them to confirm that a product was in fact reasonable and necessary, and that there was a sufficient evidence base that it would be effective specific to the Medicare population. With that said, and let's remember, the previous administration was referring to the valley of death, this period in between when the FDA approves a product and CMS makes a decision about whether or not Medicare is going to cover it. CMS did acknowledge that there's more that can be done to address the current uncertainty around Medicare coverage of new technologies, and basically said we're going to come up with something else. And then fast forward to June of this year, after a number of months of foreshadowing, speaking publicly and publishing a journal article here or there about what they're looking to do, CMS released a notice, and it was a notice, not a rule, in the Federal Register that established what's called the Transitional Coverage for Emerging Technologies, or the TCET pathway. And this pathway relies on a critical term called coverage with evidence development to help CMS develop a larger evidence base for these products coming to market. So what is coverage with evidence development? Going back to when the NCD or the LCD is reviewing whether or not a product should be covered, the CED is a pathway in which CMS actually says it is not sure whether or not this product should be reasonable and necessary, but it is willing to pay for the product and related services to make sure that the product is available, specifically for the purposes of advancing research and better understanding the effect of this product. So as a condition of Medicare's coverage for these items or services that receive CED, the beneficiary receiving the product has to be in a position where the data is able to be collected by that patient. A very prominent example of CED used recently would be a class of therapies called monoclonal antibodies directed against amyloid for the treatment of Alzheimer's disease. This refers to this new class of therapies that are coming to market specific for treatment of Alzheimer's. CMS assigned a CED for that entire class of therapies that basically says Medicare will only cover the product if the beneficiary is at a minimum enrolled in a patient registry or some other study where their information is being collected and CMS can collect more data about the therapy.
And Dan, I think one thing just to, I think this is such an important point. The Alzheimer's decision is a bit different than coverage with evidence development for devices. Coverage with evidence development for devices and for some major devices has been around for a very long time. And the conditions are different than the conditions that were applied to the kind of one of the first, if not the first time coverage with evidence development was applied to a class of drugs. So I just didn't want to, I wanted to make sure the audience knows that there hasn't the real controversy around Alzheimer's, coverage with evidence development for Alzheimer's, a whole class of Alzheimer's drugs, does not necessarily mean that there's controversy around coverage with evidence development for medical devices.
That's a very fair point. I think CMS's decision there was certainly significant, and to your point, has raised a lot of controversy. But there have been other times historically where CMS has used CED, and I think the results have been less controversial, is what I'll say. And I'm happy to share some resources if folks want a sense of other products that have gotten CD in the past and what that looks like.
Excellent.
So in talking about the TSET pathway, a lot of the work with CMS is going to start prior to the FDA approval. So initially, a manufacturer can self-nominate themselves to participate in the TSET pathway, and that happens around a year prior to the anticipated FDA decision. CMS would have 30 business days to make a decision on whether or not the product should be eligible for the TSET pathway. And by the way, CMS is also going to conduct their benefit category determination in advance of the FDA approval, and anything that didn't hit the benefit category mark would be discarded along the way. So after this initial decision for CMS to take a product on the TSET pathway, there would be an evidence preview, quote unquote, where the manufacturer would share with CMS, and ARC refers to an agency in HHS called the Agency for,
Healthcare Research and Quality.
Yes, excuse me.
A lot of us, yes, you have to kind of
focused entirely on research. So they would meet with the device manufacturer and get a glimpse at what kind of data the manufacturer has at the moment. Out of that meeting, they would work together to develop what's called an evidence development plan in advance of the FDA's approval of the drug. So once the FDA approves the drug, CMS launches the national coverage determination. And if everything holds up according to plan, based on these pre-NCD discussions, CMS would apply CED, the coverage with evidence development, to the new device, which would mean that Medicare would pay for the device and related services over a certain period of time under the condition that the manufacturer and CMS are able to collect sufficient data to support evidence development. Now, CMS did mention that they would do their best not make these one-offs, say like, this is our national coverage determination just for this product. If there are a couple products coming to market that are similar, they would do their best to issue a broader coverage determination that could cover multiple classes. But the important thing here is CED is not supposed to be an indefinite solution from CMS's perspective. CED is supposed to be a time-limited opportunity to collect additional data so that CMS can make a final decision up or down on whether or not a device meets the threshold for reasonable and necessary from their perspective. So at the end of the initial evidence collection period, CMS would initiate a reconsideration of the NCD and, as in essence, either make a decision there, continue the CED if there's agreement that they need to collect some additional evidence, issue a non-coverage, or in the last instance, they could actually decide to defer to the individual MACs on whether or not coverage is appropriate using their own discretion. So that would again be the LCD process or the claim by claim process. Now, this is a chart. I did not make this. No pride of authorship here. I stole this from CMS. They put it on their fact sheet and in the rule. But this gives you a sense of the steps. So pre-market, again, you have all of these things happening, and most importantly, the approval of the evidence development plan, where CMS, ARC, and the manufacturer agree on a plan to develop the evidence that CMS believes it will need to prove that a product is reasonable and necessary. So when you hit FDA authorization, you launch the national coverage determination process, and the coverage with evidence development starts. In theory, this whole time, CMS, the manufacturer, and ARC are all on the same page about what kind of data needs to be collected for CMS to feel confident in their decision making. So then you have your 2 years of TSET coverage where you have periodic check-ins, and then here is where you start having to periodically reevaluate with CMS whether or not the CED should be extended or whether or not CMS has seen enough. The two key points I'd mentioned about TSET, just in comparison to MCIT, what we were talking about earlier, there's no automatic coverage, no automatic Medicare coverage for any FDA-approved breakthrough devices. So to be very clear, the MCIT rule wrote into federal regulation that if a FDA breakthrough device received FDA approval for marketing, with just a couple of other conditions, you'd have automatic Medicare coverage. The TSET process actually doesn't involve any change in federal regulations. There's not actually any change in policy happening here. What CMS is outlining is a change in process in how they would work and agree to work with manufacturers in advance of a product coming to market to develop a base of evidence that will support CMS making a final coverage decision on whether or not the product is reasonable and necessary. And to help with that, CMS also released first a draft guidance document outlining what CMS looks at during the NCD process. I think there have been times in the past CMS has criticized for being a little bit of a black box in that process, and CMS tried to provide a little more information about what they're looking for. And then secondly, in the coverage with evidence development field, CMS released draft guidance outlining the principles for coverage with evidence development, and importantly, providing a sense of what CMS is looking for in terms of standards for clinical studies that CMS would support. And on the latter point about what CMS and HHS are looking for in these clinical studies, this most recent draft guidance is not the first that CMS or HHS have put out in the last year or so. ARC put out some additional draft guidance last year around what they're hoping to get out of these clinical studies, and what is important evidence development for them and how those studies could be structured. So CMS is trying to provide a little bit more information to the field on what they need to make a decision. So I have hit the end of my presentation here. I have successfully talked longer than I intended to for the 15th consecutive time, I think. But happy to take any questions, or Ellie, any questions from you?
Yeah, I certainly do have questions. And, I think the first I'll start with, I'd like to say that one of the things that's very heartening about this, if you think about this, if you kind of take a step back. So FDA for certain products decides these are really particularly important for patients for different reasons. We're going to try to responsibly speed up the approval or denial process of these devices. And for the first time, and thanks to the Trump and Biden administration, I think for the first time, or one of the first times, they're really saying, CMS is saying, we've got to try to do for coverage what's being done by FDA to increase the value of medical progress by getting it into the hands of more patients, because the sooner it's available to patients, the more patients benefit and the higher the value is of medical progress. So kudos to both administrations for this. The Biden administration took a step back, but I think that you said this is not actually a new regulation. This is actually an agreement to kind of do things differently. Is that with some guidance around that?
In essence, yeah. What CMS has said, they have always had the authority to do coverage with evidence development in the past. And as we've mentioned, and Ellie, you mentioned, CMS has used coverage with evidence development for, I don't want to say decades, but certainly many, many, many years. What CMS is saying here is we have this tool with coverage with evidence development that we would like to use, but we understand too that it can be challenging, or it might be challenging for manufacturers to have a good sense of what we as CMS are looking for in terms of our evidence base to prove that a product is going to be reasonable and necessary. So if we can sit down with you a year in advance of FDA approval of the product, we can work together on a plan to make sure, this evidence development plan, to make sure that we're getting the evidence that we think is going to allow us to make a decision. So nowhere in there have I said, and now CMS is changing its standard for coverage with evidence development, although arguably putting out these principles could be interpreted as sort of refining that policy. It's really about CMS making this commitment to do more work in advance of the FDA.
Advance. So let me ask you,
yeah,
absent this, would there be situations in which a breakthrough medical device would actually not be subject to coverage with evidence development, where it would actually just go straight to a national coverage decision or to local coverage decisions?
Well, that is the CMS standard. So going back to the world before MCIT, which were sort of the first couple slides we talked about, the way CMS has traditionally approached whether or not an item or service should be considered reasonable and necessary is either, number one, you offer this national coverage determination process. Number two, you have the individual MACs, the contractors who can do their own coverage determination process, and that's a 9 to 12 month period, or it becomes a claim by claim basis. And in many cases, products sort of seamlessly come to market, and you don't hear about these types of coverage determinations. But if there is ambiguity or confusion about whether or not a new product should have coverage, then CMS can go through this national coverage process, and you could have different outcomes. CMS could issue coverage, CMS could issue coverage with evidence development, or CMS could issue non-coverage determination.
Well, listen, I'd love to get to some of the concerns that have been raised, that kind of efforts to refine, to offer input. And I understand there's a comment period open now, not for much longer, but there's a comment period open about this pathway. Is that correct?
Correct. Yes. I'm sorry I didn't cover that in my remarks, but yes.
No, that's why conversation is good. It's coming up quick. It's maybe end of next week, or I don't know if we can put that in the chat too. If Sam, if you could look into that for us. So
the comments are open until August 28th.
Yes. So, tight turnaround here. Some of the concerns that I have heard, and one of them that I really don't quite understand if this is what CMS has said, why they've said this, is that diagnostics are not part of this kind of early discussion pathway. Is there any reason for that? Because you think about diagnostics, and that they are really the fastest path to reducing medical error and reducing costs. They are, they're so important, not to mention their role in healthcare generally.
Sure. I don't have a super specific answer, and obviously for the regulatory nerds out there, you'll of course acknowledge that diagnostic tests, as I understand it, follow under the FDA's definition of device. So there would seem to be a logical sort of not outgrowth, but a logical path there. But I can't speak specifically as to why CMS didn't choose to include diagnostic tests here. It could have been an issue with volume. It could have been an issue with something else. But for certain, diagnostic tests are not included at the moment. And that was also something that came up during the MCIT process as well, as CMS was asked, well, these diagnostic tests have gotten the FDA breakthrough. Are they all now going to get automatic Medicare coverage? And there was some sort of further consternation on that issue at the time too.
Oh, I bet. But the answer was no, right? They weren't. Yes. Going back to the notion that this is not an actual regulation, has that raised any concerns among anyone in the community?
I would say I think it's being noticed. And I think in candor, there are a lot of folks who are working, toward the production and release of devices where their initial reaction to the TSET rule is going to be, it's not MCIT. It's MCIT was offering this guaranteed pathway forward. And as you talked about, Ellie, TSET seems to be largely a commitment from the agency to work together with people. Like, it is not a change in federal policy. So my opinion is some of the reaction is going to be based on how it goes the first couple times. Like, does CMS really have the bandwidth to be spending all this time individually with manufacturers in advance of a product coming to market? Is CMS meeting its obligations? Are those who are bringing these products forward feeling that CMS is operating reasonably in their expectations around evidence development? Or is CMS setting unrealistic bars for folks to meet? I think that is going to be something that plays out over a while, and I think that will shape people's opinion on how effective the TSAT regulation has been.
Yeah, and I just want to remind folks that MCET, I try to get these right, but MCET was the Trump administration regulation that would have actually Medicare would have been required to cover within some period of time, right? Any breakthrough device. Even though under current law, Medicare does look at whether devices and drugs are reasonable and necessary for the Medicare population. So that would have been a very big change in policy. Research America hasn't taken a position on any of this. We're sharing information, particularly because we do think this is so important for patients, and that there are efforts by the administration both administrations to align speed with speed, responsible speed with speed. We'll get back to more of these concerns that maybe patients should keep in mind, things that are liked about this that patients should keep in mind, and how, if anyone wants to weigh in, how do they do that? But there's some questions in the chat I see from Nancy Valentine. Could you give a few examples of breakthrough devices and whether they're actually prioritized or ranked versus on urgency?
Sure. So I can't give a lot of firm examples right now because I think CMS just released this pathway 2 months ago for public comment. So I think folks in industry are still reacting, number one. And number two, I think folks will have to decide if they want to go through the TSET process.
Oh, I think this is FDA, right? The breakthrough designation.
Oh, apologize. Sorry.
No problem. I was confused at first too.
Sure. There is a full listing of FDA products that have breakthrough designation.
Oh, perfect. We'll put that. That would be awesome to put into the chat.
endeavor to pull that up here.
Yeah, and Nancy, it's really kind of interesting the way that the breakthrough process works. We can certainly get more information out there about it in terms of the
Yeah,
prioritization and that kind of thing.
the link from the FDA I shared in the chat earlier, which I'll repost here, does have a list at the bottom of products that have gone through FDA breakthrough and are now currently out for marketing. So I think that should be helpful for people.
So Dan, another concern I've heard is that, CMS, this is an advocacy issue if there ever was one. And that is that CMS, their operating dollars are not an entitlement like coverages. It's actually appropriated dollars each year. And they are on a shoestring budget to handle what is critical, and that is getting these medical advances to patients, to Medicare patients, to Medicaid patients, to CHIP, the Children's Health Insurance Program patients, setting a precedent for private insurers often in terms of their coverage. So, one area to really think about for all of our communities is how to increase resources for Medicare, I think, to do what it does in good faith, tries to do in good faith, and that is manage the coverage side of things. So I wanted to put that out there, and I know that that's a concern that has been raised, is right, there are only a certain number that they're going to allow to go through this process. Is that right?
That's correct. Yeah.
Yeah, it's a small number. There's another, let me turn here.
It's up to 5 each year. Sorry, it's the specific number.
Yeah, so 5, just on the face of it, it would be nice for them to have a bit more flexibility.
Due to current CMS resource constraints, we do not anticipate the TSET pathway will accept more than 5 candidates per year. So to your point, they say it right there in black and white.
Right. And you think about breakthrough to patients, if the problem is resource limitations for Medicare, that's something to really think about. I want to turn. Oh, I'm sorry. Go ahead. Sorry.
There's a recent example that I'll just mention to the group here that I think is relevant. So in the Medicare's payment to hospitals through Part A in the DRG system, Medicare makes a lump sum payment to a hospital for somebody who comes in based on a condition. They don't sort of bill out all the individual parts of the stay. If somebody comes in with a heart attack or something like that, there is generally a code that CMS pays. However, CMS learned a while ago that when new and expensive, or perhaps more expensive products come to market mid-year, the existing payment levels may not be sufficient to cover the cost of these newer products that may be more expensive than what's out there right now. So CMS had created something called a new technology add-on payment, where CMS pays an additional amount on top of the normal DRG for a new product coming to market. And that NTAP process is pretty important for innovative products that are coming to market. Well, this last year, this past rulemaking cycle, CMS announced, well, in the past, if you had FDA approval by July 1st, we would consider you in our annual rulemaking to receive an NTAP beginning in a couple of months. In the most recent rule, CMS said, we're getting too many applications, so we need to move that FDA approval date back to May.
Wow.
So you have FDA approval for a product by May if you want to be considered in that year's rulemaking process.
Again, regardless of the significance of the medical advance.
Correct. But again, it comes back to your point about CMS saying we literally don't have the time and the resources to review everything being thrown at us. And now there's a downstream impact to federal policy.
We're acting in good faith, but Nicole Bashi has a very interesting point. She's with the National MS Society. And they pointed out that not all Medicare beneficiaries are 65 plus. That's absolutely true, right? Medicare disability, others, ESRD. And she says, so even if older individuals aren't included in clinical trials, which we think they should be, the device could still be appropriate or necessary for individuals on Medicare. That's a really good point. It's the devil's in the details thing. And in this case, it's the angel in the details, because the goal is to refine this pathway, I think, again, to make sure that we maximize the value on medical progress by aligning the coverage timing with the FDA timing as much as we possibly can. Dan, are there other concerns that have been raised by the community? And I don't know if we're over time. Do we have an hour of your time? I hope so. Pretty please.
Of my time? Oh,
yeah.
You got me as long as you need.
Awesome. Okay. Are there other concerns that have been raised by the community? Not concerns, but ways they think they can refine this process to, just as you're providing comments to CMS?
So I think folks are generally processing what CMS put out at this point. Again, I think a key point is just the difference in the level of certainty that CMS had previously been shown a willingness to give through the MCIT rule versus where CMS has gone here. I mean, CMS has said, heck, we'll work with you, but there's not sort of the safety net of a designated policy saying Medicare will cover these things. So I do think there continues to be a wait and see approach. I would not be surprised to see folks in the innovation community pushing CMS to be as transparent as possible and to be as flexible as possible in this process. But I think we're going to need to wait and see how implementation goes before we'll have sort of more concrete feedback at this point.
That makes so much sense. And I think that always makes things better, right? If there's real communication that is happening with all of our communities within the R&D ecosystem and with patients in particular, and clarity about CMS's intentions and the way that the community perceives what they're saying, so kind of back and forth conversations. So I hope in feedback to CMS, if there's need for additional kind of interactions, meetings with patients and that kind of thing. And our partners, the National Health Council, are so great about that, about bringing patients to the table to talk to CMS about these issues. And I have this awful fear that I may have missed questions in the chat. Sam, can you join me and let me know if I've missed any questions?
I think one high-level note I can make as we're going through here, I do think there's, I think some thematic nervousness in the community about where CMS has been going. Maybe not specifically on this policy, but in a couple of different places. So just sort of stating some observations.
That'd be great. Yeah.
Yeah. A number of years ago, CAR T-cell therapy came to market. CMS initially proposed a coverage with evidence development policy, although they backed off. CMS pushed out the MCIT rule and then repealed it in its entirety to settle on this policy, which is a little bit different and does not offer a guarantee of coverage. And then you mentioned the more recent controversial decision about the Alzheimer's therapy that's coming to market. I think there is some concern, and folks have noticed a number of these sort of points along the way, that CMS might be interested in becoming a more cautious payer than they have in the past. The concern that CMS raised in the CED policy with the Alzheimer's therapies was about a lack of evidence. The concerns that CMS cited in repealing MCIT was concern with access to evidence. So is CMS now going to be looking for a different standard of evidence or development than maybe they have historically? Number one. And number two, would a different administration look at these evidence standards differently? That's sort of a open-ended question. We don't know. But what we do know is, there are these different data points that suggest CMS is being setting some standards for coverage that may not have been there previously and in other points in history.
I think this topic has come up, or this issue has come up before on our alliance discussions. And again, for patients, the question is so important. It is because, again, the value that the total value of medical progress is connected to how many patients benefit from it. And so, and that time is of the essence in that case, but you don't want the wrong advances to get to the wrong patients, or unsafe advances to get to patients. So FDA and CMS both play really important roles, but it would be really great to get more clarity on how CMS is perceiving its role versus FDA's role in the advances that should be accessible to all patients and the advances that should not be, and why. Where do their responsibilities lie? How are they coordinating? I think those are open questions that are really fair game for the patient community. And again, I think the National Health Council and patient organizations, other patient organizations in our alliance and outside of it, have been so great in respectfully raising these questions. And I see that it's arising here too with TSET.
No, I think that's a very strong point. The one other thing I wanted, and I apologize for just bringing this up here, but adding to sort of my previous list, I think there's been a lot of skepticism about products coming through FDA's accelerated approval process. So CMS's initial coverage with evidence development decision applied to products that came through under accelerated approval. In addition, CMS has also announced that they're exploring a demonstration project that would actually reduce Medicare payments for therapies approved under accelerated approval until all the post-confirmatory trials have been completed. So literally using Medicare coverage or Medicare payment as kind of a stick to drive more rapid evidence development on the back. Again, coming back to this theme with CMS saying we don't feel like we have enough evidence based on what the product has gone through with the FDA to make good coverage decisions. So how can we help with that evidence development? And
and
this is another approach.
I've got to say that raises a lot of questions, because FDA is standing behind an accelerated approval process that is, to patients, it means that the status quo doesn't necessarily have to be the status quo, that we could try in good faith and responsibly to speed products to patients, and then for there kind of to be a penalty when that pathway is used. It's something just to think about. Again, Research America, we have a diverse alliance, and thank God for all the input we have. So we really refrain from taking positions and just listen and monitor. And, we'd love to hear from folks on their perspectives on all of this, always, as we're thinking about which alliance discussions make sense going forward. But I do think these questions are really important to how medical progress looks in the future and how many patients benefit. Sam, let me ask you, I see another great question from Nancy. it's a biggie. It's a kind of a metaphysical question in a sense. And so, Nancy, you and I may need to talk about that one offline. But are there other questions in the chat that we missed?
Yes, I think we have one here. What is the approach for diagnostic devices that are similar to already approved FDA diagnostic technologies? Is there?
So again, CMS is sort of reasonable and necessary standard applies. But one of the things, and Ellie, I apologize, I was reading while we were talking to try to see more about the decision on the diagnostic tests. I guess CMS's perspective is we've traditionally left it up to the MACs, the individual MACs, to make decisions on new diagnostics.
Those are the local coverage providers, like Palmetto,
correct,
Blue Cross, and whatever it is that does local coverage decisions.
Yeah. And I think they are trying to steer clear of creating any national policies that would sort of make a judgment on the diagnostic tests either way.
Wow. That's interesting.
Yeah. So I think, CMS feels like they have their standards out there and that the MACs are best suited to make these individual decisions, which is why they don't want to wind up bringing in the diagnostic tests into the TSET process. They want to save that for other types of devices.
Well, I'll say that that's not something that I would have the sophistication of what makes sense and what doesn't make sense between CMS and FDA on that. But it does lead me to one piece of information I wanted to share that's relevant to this. And I do know that there is a sign-on letter that's open to anybody in the community that is a set of comments on CMS's TSET guidance or whatever it is that folks are commenting on. I can't say, and certainly Research America doesn't have a position on that sign-on letter, but we didn't really get to how patients could consider whether or not they want to weigh in. If they want a copy of that letter, could you shoot me or Sam an email, and we'll try to get hold of it and just forward it to you. Again, dispassionate here since we don't have a position on it. But I do know, if in case anyone is interested in just seeing what others are commenting on, and there is a sign-on letter out there. My goodness, it's 12:58 already, and we have a little bit of housekeeping to do. Dan, could you join Research America's team, because you're wonderful. We adore you. I don't think we can get you to come from Cleveland here, but where you are. But it's been so great having you join us. And I think this has been a really good conversation, and more to come. So Jacqueline, if you wouldn't mind joining us to do some of the I know we have a couple of announcements.
Yes, we do. Thanks again, Dan and Ellie, for this great informative discussion. And thanks to our audience for tuning and joining in. The registration link is now in the chat. And we hope you can join for our next Alliance discussion on September 7th with Dr. Jared Skillings, Chief of Professional Practice at the American Psychological Association. He'll be discussing a very important and timely topic, especially as back to school season is starting. As we all know, our world is more connected than ever before. Our communities lie at our fingertips, from Twitter, or now X, I keep calling it Twitter, to Instagram, to TikTok. But does interconnectedness have its drawbacks? What does it mean to grow up in a world where your community is online? Dr. Skillings will discuss how social media is affecting our youth and share insights from APA's recent report about this topic. Additionally, he'll cover APA's priorities in the area of adolescent mental health. So with that, thanks again for joining us today, and we look forward to seeing you again soon. Have a great afternoon.
Thanks, you all.
Thank
Take
you.
care. Thanks, Dan. Bye.